So
I can see. I can see. Oh, wonderful, wonderful, sir. Welcome, welcome, welcome to this evening, Dr. Subramanian.
Sandal Kumar.
Sir, thank you, sir.
Thank you, sir. Thank you for joining. Thank you for joining, sir. Okay. Thank you, sir. So another 2 minutes we will start, sir, and then this will be live streamed on YouTube. Okay. The way that this runs is a lot of people actually watch on YouTube even after the session is over. Okay. So some people may be able to join now, may not be able to join. That is why. So what we generally see is like by the end, by tomorrow we will see many more views. That is what happens here usually. So last grand round, everything is the same pattern, and most people join on YouTube. One more minute later, that is at 8:30 exactly, we will start off the discussion. Abhishek, it is 8:30. So shall I start off?
Yeah, sure, sir. We are live.
Okay. Okay. So very warm good evening to all of you, and thank you for taking the time out to join this evening's grand rounds session. So now it's my proud privilege to actually introduce the eminent panelists and the presenter. So we have Dr. Surajit Burman. He's my very good friend, and he's one of the earliest practitioners of vestibular science as a standalone specialty. Okay, that is a great thing, and it happened many years ago. He did his MBBS from Guwahati Medical College in 1999, MS ENT from Assam Medical College, Dibrugarh. He trained in neurotology under the eminent Dr. Anirban Vishwas in 2010. Presently, his designation is as consultant in the Vertigo Clinic, Audio Care Guwahati, in Nightingale Hospital Guwahati and Pratiksha Hospital Guwahati. He is the director of GVSB Group, GVSB an acronym for some of the big names in the Northeast. Then he was an invited faculty and gave very wonderful lectures in BalanceCon 2017, 18, 19, NES 2018, NES 2019. Is a faculty of the Indian Association of Otolaryngology and Head and Neck Surgery Conference 2021. Many publications he has in regional, national, international journals, and an innumerable number of presentations in conferences. He was awarded the S. Kumar Award in NEBA Icon in 2007, awarded Hiranandani Award in the NEBA Icon 2017. And he is also the past editor of the annual journal of NEBOI, okay, that is Northeast Journal of Otolaryngology. So this is about the brief introduction of one of our panelists presently, that is Dr. Surajit Burman. And when it comes to Dr. Balamurugan, okay, he was there with us in the last a month's session, and we know the beautiful discussions that he had. Okay, he's an MBBS and MD from Tanjavur Medical College, and he's a DM in neurology from NIMHANS, Bangalore. Okay, he has innumerable number of presentations, including Best Paper Awards in Diamond Epicon 2005. Okay, Ibrahim Bailem Oration for Tropical Medicine 2011, he was awarded. He's a fellow of Indian College of Physicians 2015 and fellow of Royal College of Physicians 2019, fellow of the American College of Physicians 2021, Teacher Par Excellence Award. Okay, this award was given to him in South Zone Apicon and Tapicon. And more than, like last time I counted the number of lectures. Okay, it's 150, 200, something like that, and a huge number of PubMed indexed publications. Okay, currently he's the consultant, currently director and consultant neurologist, Sims Chellam Hospital, Salem, Tamil Nadu. He has many firsts to his credit. Okay, including for Parkinsonism, the implants. Okay, then he's a very beautiful writer, and he has written multiple patient literature books, very nice books, very illustrated books in Tamil language. I had the opportunity to actually peruse those books and really fall in love with them. They're really, really nice. So I cannot read the language, then I saw the illustrations. They're all very well made. So with that brief introduction, I request Dr. Balamurugan to today talk and present his cases of late life recurrent falls and take the discussion forward, post which we will have a panel discussion. We'll also answer questions from the delegates who are attending this session. So over to Dr. Balamurugan. Sir, it's all your stage.
Yes. Good evening to you all. At the outset, I thank Srinivasan and Vertigo team for including me in this elite group of Vertigo specialists. So my interest in Vertigo started nearly about 2 years before, when we bought oculohistogramogram. So whatever thing that we started seeing clinically, we could document, and then I bought that machine especially for my interest in neuro-ophthalmology. So I bought it mainly for neuro-ophthalmology documentation. And then the interest in Vertigo had come up, and then lot of rare cases. So last month, Shini came to our clinic, and then he was with us for 2 days to give, to enlighten us about a lot of science in the oculohistogramogram, and we really enjoyed, and we started pursuing that again. Now, my special thanks to the panelists and all the people, and it's a small group so that you can stop me at any time so we can have a discussion. And the topic is late life recurrent fall. I divided the topic into two to start as a starter. How common this entity? Fall is a fall, sometimes a drop attacks. What is there any difference out there on how do you assess clinically when a patient presents to your OP with first attack of fall or recurrent fall? And the majority of my discussion will be of rare or tough calls, what I had seen as something as fall in my OPD or in our hospital. So we'll be discussing some case studies, and in between we can have questions and answers also. So we all know about 30% of the adults aged more than 65 years reported at least one fall in the past year, and 10% reported a fall related injury. So it tells the magnitude, and nearly 50% of the individuals in the long-term care fall yearly. So almost 60% of those with a fall, history of fall in the previous year, will have a subsequent fall. So any person coming to your OP after the age of 60, though they don't tell the history of fall, it's our duty to ask, because it prevents the injury and so the morbidity and mortality related to it. Generally, we give importance to the age and sex. Again here, as people becoming more and more aged, there is more chances of fall because of multifactorial. And women are more commonly affected in terms of falls and fall injuries in comparing to the men. And the important consequence of falls is that at least a third of persons develop a fear of fall after the event, resulting in functional decline and a progressive decline in weight. This is a really a major disturbing morbidity we see after the age of 70. Sometimes we get confused with the fall and the drop attack. Most of the textbooks authors use this interchangeably. there any real difference? A drop attack is defined sudden fall without any warning, but very difficult to get from the history. Syncope also, especially cardiac syncope also, they can fall without any warning. They may not have a pre-syncope. So that's the reason most of the authors use these terms interchangeably. It's like, what's the difference between vomiting and projectile vomiting? Somebody says projectile vomiting, it means without nausea, they have vomiting. So otherwise, they have nausea and vomiting. So we call it vomiting. That's only one way of differentiating. But more than that, somebody says projectile vomiting, it means that, oh, I'm dealing with or hearing a case of raised intracranial pressure. Similarly, somebody says drop attack in neurology, and particularly in neurology, it means mostly some third ventricle colloid cyst. How many of us had seen a drop attack of colloid cyst of third ventricle? Very rare, but drop attack means something in the midline causing a CSF dynamics. But it has been reported in a number of other neurological cases, including TA involving the vertebrobasilar insufficiency or cardiac arrhythmias. And moreover, the typical drop attack you can see in Meniere's crisis. So this I got it from YouTube. Carefully see the person in a red shirt. Seeing that I increase the height of my parapet walls. See that? Is it a fall or drop attack? Yeah. He was saved. So again, I just replay it. So see that I really surprised the reflex that blue shirt had. See the reflex, unimaginable reflex he had. So you could say that man more than the fall that what I noticed. So really an appreciable reflex he had. So, but that man had a loss of partial reflex. Suddenly something took away. So he had a fall and then he recovered. Fine. So I'm not going to discuss about the vestibular component of the fall because he asked me to discuss some rare case. Yeah. Can I show that? So, okay. Any guess? What is a fall? It is not my case. It's not my case at all. And so this is from American Academy of Neurology. From the CCT camera, they could get that. And he immediately got up. He was aware. He didn't lose the consciousness. So as per the history, there's a known case of Meniere's. So Tamarkin's drop attack or Tamarkin's crisis or vertigo crisis in Meniere's. I have never seen such a dramatic fall. Fine. To maintain the partial stability, we need motor coordination, starting from our frontal lobe, planning and focused attention, and execution in terms of motor cortex, basal ganglion, and cerebellum, which involves the coordination, and peripheral nerve, muscle, and minor junction. That's one part. Second, sensory inputs, it may be visual, vestibular, proprioception. There's a reason in Rombeck's, when one is gone, when it is combined with the visual and vestibular, they will have a severe fall, or when it's combined with the proprioceptive and vestibular, they will have a severe fall. And in addition, we have biomechanics, skeletal integrity, joint stability, and flexibility, and muscle strength. So when people go for total knee replacement, we are removing the joint, part of the joint, and the position sense neurons connected to that. So what are the chances of these people going for some amount of instability? And recent reports have said that bilateral knee replacement, and they have followed up for a year, the fall rate is more when they are not taught a proper gait training immediately after surgery. That's a message that we have to tell, because most of the people after the age of 65 with joint instability, or after knee replacement, they come to us with fall. That may be the reason. So it may be in intrinsic factors, risk factors, or extrinsic environmental hazard, or poor footwear, distance. Probably when you look at the population-based service, the poor footwear may be the common cause for the fall. They may go for a trips or slips, sometimes drop attacks, syncope in view of a cardiac or neurological. And finally, there's a fall that they present to us. So how do you evaluate a fall, history of fall, like a seizure? What are the questions that we ask? That we know age, elders are more prone, women are more prone. Is there loss of consciousness? That gives some idea about, is it a vertiginous fall or something else? That gives them some idea about that. If so, is it a transient loss of consciousness, or the patient lost consciousness for prolonged? That also gives them some idea about epilepsy or non-epileptic event, or prolonged event. Is there history of seizures? Again, long-term epilepsy patients having a fall is different. Is there associated motor, sensory, cerebellar, pyramidal symptoms? Then go with raised ICT features. Then pre-existing illness and medication. That's the most important part, practically speaking. History of diuretic, vasodilators, or combination of multiple antihypertensives and prostate, drugs for prostate. All those things may cause a drop in the BP, and we may miss that. So, and nitrates. History of visual impairment, hearing, vertigo, tinnitus, that may focus our examination towards vestibular or oculomotor disturbances. And most important, we should ask history of the sleep hygiene, or whether they have daytime sleepiness, or they have cataplexy. That may be the clue. We may be dealing with narcolepsy patients. Sudden fall. So repeated sudden fall with daytime sleepiness, excessive daytime sleepiness may be the clue. Triggers for fall has to be inquired, especially hip posture. When they get up, they have a tendency to fall. We may be thinking when they turn their head, that's a different. Mostly when they turn their head, it may be a problem with alkali malformations or sometimes midline tumors. So that has to be differentiated from orthostatic. It's different from orthostatic, we know that. And emotional triggers, especially in cataplexy. What circumstances made them to fall, or then obstacles or problem in the uneven surface, probably a pyramidal tract or cerebellar lesions. In addition to that, obstacles causing the fall, or the fall in the restroom, we think most of the time situation related, straining or micturition syncope, or it may be due to vasodilatation or taking a bath, hot bath, or the problem in the using the walking aids. An early morning fall, most of the time, it's a partial drop in the BP. And always assess the functional part, how much they could walk, what are the ability to get up from the sitting posture, turn around, what is the gait, passion, and everything has to be carefully elicited, and that may give the clue. As far as the focused examination is concerned, we do all the examination, but when you assess the fall risk in elderly, these are the three tests: timed up go test, or functional reach test, and pull test. So timed up go is otherwise get up and go. Ask a patient to get up from the chair. So this is a way that the patient has to get up from the chair with both the upper limbs extended, because the message is they should not get support. They should get up, stand, and then they walk for 3 meters, and then they make a turn around, and they have to come back again, turn around. They have to sit. So this completes 3 meters up and down turning. So when they could do within the 10 seconds, it's fine, and 10 to 20 seconds borderline. So if they take more than 20 seconds, it means there may be a problem in getting up. I will think that getting a problem more of proximal. Standing problem, it could be partial or orthostatic, or it could be ankle disability, or when the person is having problem in the gait may give us clue about a spastic gait, or they are having waddling or cerebellar, and turn around. They take time in turn around. So it may be a extrapyramidal, and this will help you to say all the neurological component. Functional reach test is the other one. You ask a patient to stand and then keep your scale, like in this picture, ask the patient to bend forward without taking steps. So how much they could bend forward. So measure in terms of a scale, longitudinal scale. A score of 6 or less indicates a significant increases for fall. When they could move their fist more than 10 inches, that's fine. So normally we could do by bending. So the pull test is one most neurologists do that. It's a normal pull test. You have to stand back and then you have to tell the patient that you are going to make a short, jerky pull backwards. So it's a normal. So, and I always say that the examiner has to stand very close to the wall. What happens here? So he should be able to support. So again, you can see that. So this is more in favor of not able to control the rate of pulsion. So this most of the time we do for examining the patients with the Parkinsonism. What's the risk of fall, especially when you are dealing with extrapyramidal component. This pull test is useful. If you're asking the questions which is more specific and more sensitive, there is no head-to-head study about comparing these things, and one of us can do that. Conveniently, we can divide fall and drop attacks interchangeably. I use here. So neurally mediated vasovagal, carotid sinus syncope, situational syncope, or glossopharyngeal neuralgia, and neurological. It could be cerebrogenic cardiac arrhythmia, brain-causing arrhythmia. The first one is problem in the heart or problem in the receptors. Second is the brain, vertebral insufficiency, TA or anterior circulation, so ACA, artery territory, or the part which supplies the leg having infarct or lesions, cataplexy, midline tumors, third ventricular cyst, colloid cyst, and subclavian stele or hyperventilation causing a dizzy and then fall, or psychogenic. Partial hypertension, most common, and if you ask me among the 5 group which is the most common, I say again partial hypertension, which is often missed because we have to examine the BP, record the BP in supine and then standing and then prolonged standing. So drugs, volume loss, dehydration, both good, very common combination in elders, and again degeneration, small fiber neuropathy, hypothalamic lesion. Imagine a 60+ person with a diabetic having a dehydration coming with fall. Most likely it's a combination of drug, volume loss, and degenerative process of small fiber neuropathy. And cardiogenic, it may be structural or electrical, structural LVOT or right ventricular, left ventricular outlet obstructions, or obstruction of the venous return, a sudden pneumothorax. So recently we had a case of a person going for a recurrent syncopal event and turned out to be a tension pneumothorax on the right side. And the patient was on ventilator. I was not able to explain that. So that turned out to be a tension pneumothorax in ICU setup. So then electrical tachyarrhythmias, 3rd degree and 2nd degree heart block, WPW syndrome, and long QT intervals, and vestibular component is the Meniere's, especially the Meniere's crisis. So before going to the tough calls, the case studies, we have discussed the part 1. We know that that's a real problem in the elderly population. Our job is to identify the risk factors and to give protection, and we have to evaluate them. What's the chance or risk of fall, and the clinical assessment is all the 3 tests we can take up. And I go for pull test when it's more of basal ganglionic, and then I go for get up and go when they have a more of proximal or motor instabilities. So this is a way that you can assess, and then you can educate them. And I repeat, it's a history is the most important to get the drug history. What are the circumstances? What are the precipitating? And always check the pulse. ECG or a Holter echo may tell about the cardiac event. BP tilt table may tell you about partial hypertension. Focused neurological examination, especially on the gait, will help you to tell the basal ganglion, cerebellum, and perineal tract involvement. Vision, hearing, especially acute loss or sudden change in the vision or diplopia, hearing and vestibular assessment will give you an idea about the vertigo or its peripheral component. And joint instability, especially post-op cases, or I'm not telling about immediate post-op. After 1 year, follow-up of total knee replacement patients are more prone for joint instability and then fall. And fear of fall is the one major issue because of the age, sex, female sex, and obesity. These are all the precipitating factors for fear of fall. One fall, that's all. They develop fear of fall. That precipitates the change in the gait that causes more fall. I can take up any questions with this part before moving on to the case studies. Dr. Srini and panelists, any inputs, any comments?
Sir, what I think is maybe we'll go ahead with the case studies.
Sure, sir. I'll go.
Then what will happen is then we can take together, then we'll have more doubts.
Sure, sir.
Sure, sir. Sure, sir.
So that's a case one. Okay. So just you all can see this video and you can have a mental picture. This gentleman came to us for evaluation of recurrent fall. So you can get the history, detailed history. That's different. But this is recurrent fall, nearly about 4, 5 or 6 times of fall within the period of about 2 to 3 months. So now you can witness the fall. So, and you can comment in the comment box, what do you think the fall? So again, I show the event. So a day, it took nearly about 15 to 16 seconds. At the end of 20 seconds, absolutely normal. It's back to normal. So how many of you say this is a syncope? How many of you say this is a seizure? How many of you say it is a functional? Or you can have things in your mind. And because we easily ask questions to the patients, what happens to the fall, whether the eyeball rolling upwards, whether hand was turning this side, that side. But after seeing this also, we have sometimes doubt, witnessing the attack also. Because I had seen repeatedly the video, I could say whatever things happened about the 15 seconds, but very difficult for the attenders to tell whether there was uprolling of eye, whether the eyes was closed or I was blinking, or whether a grunting respiration was there or not, whether the hand was going in abnormal posture or not. Everything was there, but very difficult to point out. Okay, fine. This 76-year-old retired teacher referred for evaluation of recurrent attacks of transient loss of consciousness, in TLOC, transient loss of consciousness, lasting less than 10 to 20 seconds. So for 6 attacks over the last 1.5 months, the description of the first attacks was, while he was mopping the floor, his wife heard a sound and saw him in the floor in unconscious state. Within few seconds, recovered fully. No slip or imbalance before the fall. The floor was not slippery. No prodromal symptom. It was a sudden fall. He didn't experience giddiness or blackout before fall. No post-event headache or confusion. He got up absolutely normal within another 5 seconds. Then had a cup of coffee and was normal. After 30 minutes of the first attack, while he was standing, had a similar attack, which lasted about again just 10 seconds. Sudden fall, LOC, recovered within few seconds. So with that history, general practitioner thought that fast he recovered something. He said that uneasiness, probably they would have told something, a spinning sensation, and they thought it's a vertigo and started on as usual vertigo. Patient took that for 3 days and stopped. So after about 10 days of second attack, while listening to his wife, of course, standing posture, had giddiness and sat down. He had no LOC, recovered within 10 seconds. So he said that he had some feeling of fall and he didn't lose the consciousness. So they didn't consult any doctor. 1 week later, while standing in a queue, had giddiness, fell down and lost his consciousness for about, again, all are less than 20 seconds and recovered immediately. Due to fall, he injured his forehead. So there was an external scalp hematoma was there. So on the same day, while at bed in supine posture, this is one thing different. I have put it a green color now. So had sudden onset of spinning sensation while turning his head, lasted for about a minute. No LOC, no vomiting. So weather history, his son is a cardiologist, one more son is a endocrinologist. So they evaluated thoroughly. So because old age, they thought it could be a problem in the rhythm. So ECG normal and echo mild atherosclerotic AS, but he was very clear, no LVOT obstruction. And they did a Holter monitor for 3 days, no clinical or electrophysiological event during the 3 days. So hence he was referred for a neurological evaluation from the cardiac part. So they were very clear. So there is no cardiac event, arrhythmia or structural problem. So while the neurologist was examining him, the patient had another attack, just collapsed. He wrote in the case file that there was a grunting respiration, abnormal posture of hand, and he noticed few jerks with loss of consciousness for about 10 seconds and record. Again, it was just 10 seconds. Order for MRI and MRI normal, EEG was normal. Within another 2 hours, they have done everything. And probable recurrent attack of LOC, he had witnessed this abnormal posturing and respiration. Probably he thought that cardiac was also normal. He thought it could be a levetiracetam and could be epilepsy. So started on levetiracetam. And old age, first attack of seizure or second attack of seizure, he thought that it could be a vascular phenomenon, not picked up by the MRI. So some embolic phenomena, you may have thought that he had started on ecosprin, clopidogrel, atorvastatin, and in addition, because he had one episode of vertiginous feeling in bed, so he added this beta-histine also. He went home again on the same day, while on levetiracetam, had one more attack while he was in restroom. While passing urine, fell down, LOC, recovered within 10 minutes. So they got confused. So is it a seizure, a fall, or something else that are missing? With this history, that I thought it could be a partial drop that we are missing, because that's one of my favorite diagnoses. So because most of the people, the busy OP may not be checking the BP. So I thought that I may get that clue. So by surprise, there was no partial drop at all. So it was normal, and 10 mm of systolic drop that is not significant. So after that, I asked my emergency room staff to do intermittent BP monitoring for every 3 minutes for the next 30 minutes. Because I was not happy, because sometimes we have our favorite diagnosis, So somehow that it should be a partial drop. So that was my fancy diagnosis. So I thought that I was very keen to document at the end of 30 minutes. But the history-wise, he didn't have the attack after standing for a long time. So most of the time within 5 to 10 minutes. So, but to our surprise, in the emergency room, within next 2 minutes, patient collapsed, fall, grunting respiration, recovered by 10 seconds. Again, they were recording the BP, continuous BP monitoring was there, no drop in BP. The sugar was normal and everything was normal. This was, I'm the second neurologist. So you can see, this is a patient. This is from CCTV camera of our emergency room. So see, he collapses here, just collapsed. That's all. All episodes are same. His doctor son could say that, sir, exactly same thing is happening. This is the 6th, 7th attack. Myself witnessing 3 attacks. So he'll recover within 10 seconds. So he recovered actually. So not a non-hypertensive, cardiac patient, diabetic on metformin 1 year, no past history of a hypoglycemic attack. Patient had complaints of constipation and dry mouth since 2 months and complaints of weight loss of 6 kg over the last 2 months. So this history, I thought that could be autonomic dysfunction. It could be again sensory neuropathy, diabetes versus paraneoplastic. This is all the thought process going on with the history. So I thought there are 2 types of attacks. 1, 2, 4, 6, 7, and 8 were of similar attacks, sudden fall with LOC, recurring within 20 seconds. So these are all syncope or seizure. By seizure, grunting respiration, few jerk noticed by the neurologist, abnormal posturing of the hand. So these are the 2 possibilities I thought. And in addition, 1 attack was pre-syncope. He sat down and there was no LOC. And 1 attack at bed, turning the head, produced spinning sensation, vertigo. So I thought something is missing, that carotid vertebral Doppler were normal. So we did CT chest, not suspecting anything because it was a pandemic started those periods, June. So we did CT for that purpose and normal. And because of the diabetes and dry mouth and constipation, so looked at the RR interval. So it showed severe autonomic dysfunction. So again, I was happy that autonomic dysfunction, I'm not able to document the partial hypotension. So 1 attack observed in the EEG room while standing, because I asked my EEG technician to record as usual. We always record the either in sitting or lying down supine posture. I said that after the usual record, you ask the patient to stand. I want to see what happens in the EEG. So because all the attacks are precipitated by standing posture, within 5 minutes, all the attacks are precipitated by. That's the reason I asked to stand, and this is the EEG recording going on. You saw the attack. Now I see. Now, what's your diagnosis? You can think this history. I asked him. I think there is an uprolling of eye. The eye is going towards the right side, not up, slightly towards up and right. And there is a grunting respiration. And the hand was going in abnormal posture, and he recovered. Abrupt, fast recovery. That's all. He got up. So I asked his son, cardiologist son, to do Holter in standing for 10 to 30 minutes. He was a little bit wild. Sir, already we had done for 3 days. I said that you have done it for 3 days, but unfortunately, he didn't get any attack. So you have not documented any event. But why can't you do it? Or because I'm very clear that it's not seizure, it is a syncope. So I'm very clear there is no partial drop because we have checked the BP. So why I asked the cardiologist to do Holter is that I'll see that. When we were recording the EEG, so you could see this is the ECG tracing going on. So he was swaying here, and then he was saying that some giddiness. He told the giddiness just 1 or 2 seconds before he said that he feels giddy. So you could see that ECG recording. It's not clear, but you could see that there is no waveform at all for a long period. And this is a period where it is not seizure discharge, it is an artifact, full of artifact, because he started moving. So a long period of silence, and then again the ECG starts. So that made me to go ahead with Holter, and the doctor son called me and then said that, sir, we got it. So this is a long period of silence of ventricular response. You can see the only P wave when he did the Holter in standing. Nearly about 7 to 8 beats is missing. So then he went for detailed electrophysiological study of cardiac events and turned AV nodal block, and pacemaker was inserted after that. The last now 1.5 years is over. He never had any recurrence he is doing well with pacemaker. So the lesson learned in this case is that detailed history is the key. All the attacks in standing. So it is a partial or orthostatic, but there is no orthostatic drop in BP. So we should get the attack. That's the phenomena, what we call in neurology. We should get the attack or precipitate the attack. So the paroxysmal events, better try to document, get a video clip, and we can slowly see again and again what are the phenomena we see. Is it a syncope or is it a epilepsy? That was a doubt when you see the video. You might have had the possibilities of thinking these two things. Not yet answered question in this case is that why in standing posture? It is an arrhythmia. So it is not a orthostatic hypotension. So at that point, I didn't have an answer, but there's a phenomena that I have documented. That's all. So no fall in BP. Twice we have recorded no fall in BP. We are very clear there is no partial hypotension. So syncope, we know it is a transient loss of consciousness. We have 4 components of loss of partial tone, spontaneous and complete recovery after that, and it is due to global cerebral hyperfunction. We now call it a brain heart event. It's not a heart event. The problem starts in the brain. So global ischemia or brainstem ischemia then goes to its consequences. Again, you can see the heart, and then it may be starting in the heart as bradyarrhythmias and then affects. So better terminology is a brain heart event, the syncope definition. Any transient loss of consciousness and fall. The trauma related, it could be concussion very easy. If it is non-trauma related, it could be syncope, seizure, or metabolic or intoxications. Or it may not be true loss of consciousness that we get in cataplexy. They never lose the consciousness, just they drop. And they say that they are fully aware of the fall. So, but it will be a sudden fall. So that can happen in drop attack, cataplexy, or psychogenic syncopes. So in these patients, we had a doubt about syncope as a seizure. So syncope is mostly neurally mediated or orthostatic or cardiac. Anything. So I'm not going into the theory part, and to suspect neurally mediated syncope because it's the commonest form of syncope in middle age or young people, and absence of heart disease, long history of recurrent syncope, of the sudden unexpected or unpleasant sight, sound, smell, prolonged standing in crowded places or hot places, nausea, vomiting associated with syncope may be there, or it may be during a meal or postprandial with head rotation or pressure on carotid sinus. It may be carotid supersensitivity or after exercise. So most of the time in pediatric age group, it be standing in their assembly or prayer room, they can get this neurally mediated syncope. And why often syncope misdiagnosed seizure is that transient loss of consciousness is so transient, so no proper eyewitness. So they say that he fell down. So was there any jerk? We don't know. Was there uprolling of eyeballs? Very difficult to explain that. So myoclonus in syncope, when you ask the general population, jerks in syncope is rare, sir. It's very rare, but it's not true. Nearly about 90% of the syncope patients may have 1 or 2 jerks or multiple jerks in about 20 to 30% of the individuals. It's a myth that people think that syncope a loss of partial tone, but they may be having a jerks, especially myoclonic jerks. So that may be mistaken for GTC is what happened in this case. So grunting, vocalization, posturing, few jerks may be mistaken for epilepsy. But the clue is here is that sudden onset, getting up within 15 seconds. That is very unusual for a generalized tonic-clonic seizure. It lasts for about 2 to 3 minutes at least, and then maybe a post-event confusion. So brief multifocal arrhythmic myoclonic jerks are often observed in up to 90% of the patients at the time of symptoms. These are caused by brainstem hypoperfusion or may be mistaken for epilepsy. And interested audience can go with this. It's available in the YouTube. Lampert et al. They have analyzed 56 healthy volunteers. You can see some of the, they precipitated the event, hyperventilation, squatting, and then rapid raising with Valsalva for 10 seconds, and forced expiration against. So this is a way that they precipitated in 56 healthy volunteers. So they precipitate the attacks. So you can see the jerks. So nearly about 24 recordings they have in the YouTube. You can see all varieties of all are syncope precipitated by this phenomena, hyperventilation, squatting, and then rapid raising with Valsalva. So some fall like wood, some people have it. And then the conclusion is that 90% had myoclonus and 80% had non-myoclonic movements like head turning, grasping, raising, and 40% vocalized during the syncope. So that's the reason that the article what I quoted that. So syncope, a videometric analysis of 56 episodes. So, fine. This is how to differentiate syncope. It's for general practitioners and the neurology forum. So onset of myoclonus is usually in a convulsive syncope. First fall and then jerks. In epileptic seizure, it is with fall or just before the fall they have the jerks. And it's usually arrhythmic jerks in convulsive syncope. Syncope itself can have 90% of the syncope itself can have jerks. Whether the convulsive syncope has any meaning, I do not know. So they can have multifocal jerks, and the duration is usually less than 20 seconds. Here it is usually 30 seconds to 2 minutes as the epilepsy is concerned. So the eye deviation may be upward, and injury recurrence may occur, but postictal fatigue may be there, not postictal confusion in syncope. These are the clues to differentiate a syncope and epileptic seizure. From history, sometimes may be difficult, but when they have video recording, we can do it very clearly. So a detailed history is a key. Paroxysmal even better try to document. Syncope is common in epilepsy phenomena. And here in this patient, my question is answered by this paper, syncope and paroxysmal AV block. And they could say that they divided this into 3 types: intrinsic AV block, extrinsic vagal AV block, and extrinsic idiopathic, where they could say that standing for 10 to 15 minutes can precipitate this reflex syncope due to extrinsic vagal AV block. So that was very interesting. And another group of high adenosine syncope, that also they have documented. Posture-related syncope. This patient went thorough cardiac evaluation, turned out to be AV nodal block and high adenosine type, and pacemaker was inserted, and he stopped the antiepileptics on day 2, and he's doing well, no attacks of syncope. For this case, any questions I can answer, or I can go for the next case? Dr. Srini, any doubts in this case can be answered?
Sir, I think I prefer we finish cases, then
Sure, sir.
together we'll take everything.
This is a case 1. For any discussion, we can say case 1. And go for
Yes, sir. Yes, sir. For any discussion, we can say
Yes,
case
sure.
1, and
Case
then
two.
for any discussion, we can say
I'll be
case
showing a total of 4 cases only. And
two.
case
Okay, sir.
and this is a 68-year male had a recurrent attacks of transient loss of consciousness with few jerks. 3 months duration. 10 attacks so far, especially standing. Sometimes lightheadedness without LOC, mostly on standing or getting up from sitting posture. He was a known Parkinsonism patient, diabetes, hypertension, CHD, and prostate on regular treatment. So he was on Syndopa, antihypertensive, nitrates, diuretic, tamsulosin. So now you got the clue what I'm going to trying to say that. So all attacks on standing or getting up from sitting posture, this much drug, and though there was a jerks, but these all transient attacks, and his BP very clearly said that. So what we had his BP in was 110/70, 3 minutes after standing, dropped to 80/60. So you can carefully see that. So and supine the BP was 1 1567. Those days, it was long back, nearly about 7 years before, I was not having my tilt table. Now we have a tilt table to examine this as a routine thing. Any fall that we go for, any vertigo, giddiness in elderly, we go for tilt table, which is nearly about 10 minutes test. So on sitting, his BP dropped, and you can see the drop to 60/44. He was asymptomatic. Sitting, BP dropped to 60/40, but he was asymptomatic. So we made him to stand, and he collapsed. Okay. So he collapsed. During the collapse, you could see that he was having a jerk. So it is a severe partial. You carefully see his hand. Now you can see he getting the jerks. So this all the jerks that this was confused with. So he had a jerks and then he had a palsy. So a myoclonic jerks what he was having, because by the time the BP dropped to the BP dropped to 60 Curie, and there was a rise in the pulse rate. So that was interesting, that drop in BP with rise in pulse rate. So this is another patient who is not coming into the category of elderly male. He's a 40 years, recurrent attacks of LOC of 5 months duration, again with few jerks. And more or less, it was looking like a partial hypertension, very clear diagnosis. BP drop of 130/80 to 90/60. So the pulse rate is more or less same. There is a drop in BP, the pulse rate was same. So the diabetic hypertension of late having nocturnal diarrhea. So you can see this patient. So this is our tilt table manual. He got the attack now. So I have edited that. At the end of 3 minutes, he got an attack. Again, I will show this. So carefully you can see that. Yeah, he collapsed now. So the tilt table was brought down immediately, and he started regaining. So he was having few jerks, and then he got up. Here the pulse rate was not increasing, the static. So this is the case 2A and 2B. The only difference is a rising pulse rate or static pulse rate. Both had a partial hypertension. So syncope due to orthostatic hypertension. On being a bipedalist, the illusion. So as a normal response to standing, we get it by activation of barrier reflex. Small fall in systolic BP happens, and a rise in diastolic BP happens. Rise in heart rate, nearly about 10 to 20 beats can happen. But failure of the physiology causes orthostatic intolerance. So that causes cerebral hypoperfusion. So for all practical purpose, orthostatic intolerance is divided into orthostatic hypotension, sustained reduction in systole of more than 10, diastole of 10 or systole of 20 or more than 20, and diastole 10 or more than 10. And usually within the first 3 minutes of standing or head up tilt on a tilt table, usually within 3 minutes. Or it can be a loss of consciousness due to orthostatic intolerance or partial orthostatic tachycardia syndrome, especially in young girls, lean, tall, young girls. They say that standing produces dizziness, but there won't be a fall in the BP, but there will be abnormal rise in the heart rate 30 or more than 30. So within 10 minutes of standing or head up tilt in the absence of orthostatic hypertension, it's called POTS. So very common in young, tall, lean girls. Why we should differentiate, I am stressing about the pulse rate is that the second case, is it a part of Parkinson's disease or Parkinsonism, multisystem atrophy, the is going on, or autonomic dysfunction related to the diabetes. So or is it drug he's getting? So the orthostatic hypotension is now divided as a neurogenic and non-neurogenic. Non-neurogenic usually 60, above 60, variable onset. The causes mostly drug dehydrations. Prognosis resolves when the underlying cause is corrected. There is sympathetic activation upon standing. So the heart rate increases. So that's the first case. So when the heart rate increases upon standing, but the BP drops, check the hydration, check the drugs. It's a non-neurogenic. Whereas the heart rate is not increasing, neurogenic orthostatic hypotension that can happen in a degenerative disorders, multisystem atrophy or autonomic dysfunction. So usually it is a chronic or acute on chronic, reduced norepinephrine release from sympathetic postganglionic nerves when standing up. There is no raise in the heart rate. So that's the reason that we have to differentiate these two things, and that may help us to target again drug-related thing. Or if it is an autonomic dysfunction, there is no, then we have to go for drugs to tackle the severe form of orthostatic hypotension. So with this, I move on the last case. Can I go to the last case? Yes.
Yes, sir. Yes, sir.
47-year-old male was referred for evaluation of 2 attacks of generalized tonic-clonic seizure. Detailed history is just like had recurrent attacks of transient loss of consciousness preceded by giddiness, and 2 attacks of generalized tonic-clonic seizure. So the first attacks was 4 years before. Felt giddy while riding a bike, and last about 2 minutes he stopped riding the bike, and after 2 minutes giddiness said something has happened to me, not able to recollect. Second attack, loss of consciousness, again he was not able to recollect, more or less same. And third, and so the third attack, he could say that while praying in a church in knee down position, felt dizzy and he fell down on the floor. Loss of consciousness, regained consciousness spontaneously. Something has happened to me, not able to recollect, but this time I felt the burnt oil smell. So some phenomena or hallucination he had, olfactory hallucination. Similar attacks continued for about a month, 3 to 5 per month for months together. And this is one classical attacks of went to restroom, and he started having throwing seizures involving all 4 limbs, coughing from the mouth, and post-ictal confusion. So that was preceded by deprivation. So he had this is a typical generalized tonic-clonic seizure, anticonvulsants. While on drugs, he was not having generalized tonic-clonic seizure, but he was having either giddy or transient loss of consciousness. But the patient stopped medicine after 30 days. He had again generalized tonic-clonic seizure. Again, there are 2 phenomena going. One is generalized tonic-clonic seizure. Second is recurrent attacks of transient loss of consciousness. So some olfactory hallucination. So sudden loss of consciousness and recovery. So is it syncope or TLE, or everything is a part of seizure? So investigation then, because it is a very transient, so he asked for the cardiologist to look carefully, and then they said that nothing. So TMT, echo, everything was normal. EEG, generalized epileptic form discharges, MRI normal, biochemistry normal. Patient was not able, we are not able to explain the fall in this type of epilepsy. Why? Why he recovers very fast? The syncope is something different. So again, we asked EEG with ECG tracing. So while doing EEG in sitting posture, patient felt unsteadiness, swaying, had one episode of vomiting, then became unconscious. Then regained consciousness spontaneously within another 2 to 3 minutes. During this episode of ECG monitoring, EEG, it showed bradycardia followed by asystole. After a few seconds, ECG showed a normal rhythm. You can see here. So you can see here. So he felt uneasiness here. So this is the clear ECG tracing here, 1, 2, 3, 4. Then you can see a slowing started here. slowing, and not responding to call here. So the rate has slowed in severe brady, going for severe brady, almost a long pass. Then he collapsed, and then started picking up. 1, 2, 3, they started picking up, and then again, the wave started coming up. So this is not the patient of our audience. So he gained full consciousness. So we press this ECG with EEG recording, and you could see here the normal recording here up to this point, and then bradycardia started here. So full of artifact, what you see here, and a bradycardia, and then started a normal heart rate. So this is the period where the patient started telling something is going to happen to me. I get the same feeling. So we could get some of the focus here. The same time, you could get the long bradycardia complex here. So this is ictal bradycardia syndrome. What is it? So Russell reported the disappearance of a patient's pulse during a seizure in 1960. Most studies reported tachycardia in epilepsy. Very few had reported bradycardia. The ictal bradycardia has been reported in less than 6% of the cases of the complex partial seizure. 107 cases of ictal bradycardia have been reported, but we had chance of documenting this ictal bradycardia in this patient. Ictal bradycardia syndrome, localization and radicalization. So the seizure onset was localized over the temporal lobes in all recorded seizures associated with bradycardia in 12 patients. The mean latency from seizure onset to bradycardia was nearly about 28 seconds, and these are about for epilepsy. But what we have to understand that brain seizures, heart seizures, a case of ictal asystole, lot of records. The ictal bradycardia syndrome, localization, lateration related. So when a patient is present with epilepsy, let it be temporal lobe epilepsy or generalized chronic seizure, more so temporal lobe epilepsy, if they present with unexpected collapse, loss of tone or fall, late in the course of a typical complex partial seizure, considered ictal asystole, delayed loss of tone is uncommon in temporal epilepsy. In temporal epilepsy, they don't lose their tone. They may maintain, they may be sitting or they may be standing. So when they fall and then they get up immediately, so it is not a GDCS also. In addition, the patient had GDCS, that's different. We have documented that. But this fall and getting up, so we can document as a ictal bradycardia again. So when they are going for a recurrent ictal bradycardia, pacemaker is the treatment, or we have to treat the epilepsy effectively. So the brain that attack the heart and then producing. So ladies and gentlemen, we have covered the topic in part 1 as the importance of evaluation or asking the history of fall in elderly. So it's very common after the age of 60, 65. So one fall precipitates next year, and we should have a thorough history and clinical assessment. If you ask me, the commonest cause is drug dehydration. Second is cardiac. The third is neurological. So this ictal bradycardia and AV nodal block presenting, these are all the rare. Just to stimulate you, my duty to show the rare cases also. And thank you all for your patient listening. I'm ready to take up questions and contributions from the. I have purposely not covered vertigo related fall.
Sir, thank you very much. That was an eye opener. Okay. In fact, the first time I spoke with you on that day, in fact, I had made a request to record this presentation because that is going to be useful for a lot of people. I am sure all those people who took time out this evening would be overwhelmed. Already I'm seeing in the chat, I think somebody has already written, I think I see Ravi Kishore. Okay. Dr. Ravi Kishore has already said thank you to you, and that was really an eye opener. And generally, what happens, it is like fall assessment is a difficult concept. Okay, it's very, very difficult. And when you open even Harrison's, there is not much there. Okay, most of the thing is about how to take care of them, what is the morbidity, what is the mortality, what all happens because of falls, but how exactly to go about diagnosing a person with recurrent falls is not adequately covered in even standard textbooks, unfortunately. And in fact, I can tell that because I've gone through multiple books to try to understand, and you have really put in your years of experience in a succinct manner very nicely to share your experiences and your approach. So I've taken multiple screenshots of your presentation. There are so many places where I'm sure that you gained those things over years of questioning yourself, and that is going to be really, really beneficial. At this point of time, I request Surajit to please come online. I mean, okay. Surajit boss, your comments and your questions.
Well, first of all, I must commend Dr. Balamurugan for this presentation.
Yeah.
This 4 cases not only shows how astute we have to be, how observant. This small details can lead to such a different diagnosis. The first case, the person had a son who was a cardiologist, and then even then he could not make out.
Hope he's not online.
Minute things. So,
okay.
yeah, thank you, sir, for this. I don't have any other comment other than saying that these 4 cases will, I think, for all of us present here, open a new vista. And now, every time a patient with imbalance comes in, because we will have a complete different perspective to look at. I think even Dr. Srinivas will agree to that.
Yeah.
I'm just still taking in all the information that you have given in. So I'm not even thinking of any questions right now. So back to you, Dr. Srinivas.
Yeah. So it was really wonderful. In fact, there were one thing about a rise in pulse rate and fall in blood pressure. That was a very nice point which sir was making. So all this while I was only thinking in terms of rise in pulse rate and fall in blood pressure, okay, versus fall in blood pressure without a rise in pulse rate. I think Eugenie Mempo also has said thank you, Eugenie. We acknowledge your thanks. So I used to think what rise in pulse rate, always only think in terms of a hypovolemia, maybe because of an internal bleed, maybe because of a dehydration, whatever it is. Sir also added some more things today in the plus 65 things. I've taken a screenshot. I perused that closely. One of the things is like too much of pulling in the lower down vascular spaces. Okay, maybe it could be abdominal, maybe it could be in the limbs. Okay, that was again very beautiful. So more than like asking questions, whatever questions were coming in the mind at that point of some time, some slide would come and solve that question. So that is why maybe we will not have questions. One more thing is, I think the other emotion that will be running through all those people who were going through this session is maybe were a bit overwhelmed. Okay, it takes time to imbibe all those things, but then definitely it has opened vistas. There is a new way of looking at falls and reaching a diagnosis. Thank you, Divya, for the message. Thank you so much. Okay. So, and anybody from the audience has any question to Dr. Balamurugan, you can unmute yourself and please ask straight away. It's a small group. You can unmute yourself and you can ask any questions on the YouTube. Okay, Abhishek, you can type it into the chat box and then Dr. Balamurugan will answer.
Professor Vivekanandan is there? Dr. Vivek, can you unmute and then your comments? Okay.
I think we can all understand why he got the Best Teachers Award.
Yes. In fact, he takes a lot of time out. He takes videos, goes to the medical college, teaches. In spite of his busy schedule, he goes to teach.
Vivekanandan, can you unmute and then you can give your input? Professor Vivekanandan from Japan. Are you there? Okay, fine.
I'm not sure whether he's there, sir.
And how common this? Because I have never seen minious attacks. I was surprised to see that in the YouTube on case which I showed that from American Academy of Neurology. So,
Sir, from our side, when maybe we are ENTs, that is why we see them commonly.
yeah.
So there are two patterns in which we see the mini ARS type drop attacks. Okay, one is early on, in the sense that will be the first feature of the mini ARS, and the actual mini ARS starts to develop sometime later. And there are other groups of people in whom during the burning out stage, during the very late stage, where there is a complete SNHL, everything is developing, patient would have gone through multiple things. Okay, so at that time, the patient will be getting this mini ARS attacks. And as you showed, it is always dramatic. There is a dramatic pull down or pull to one side, and patient is completely conscious most of the time. Unlike the cataplexy collapse, this is not a simple collapse. This is actually being pushed to the ground or pulled to the ground. That kind of a thing is.
One case, my colleague professor presented,
Yes.
and hit against the wall.
Yes, sir. Yes, sir.
Because of the severe vertigo. I couldn't believe that after seeing this. Really,
Actually,
happened. It
yes,
throws
sir.
the patient. It literally throws the patient out.
Throws the patient away. There is energy, there is drama there. In fact, there was one elderly patient with mini ARS with falls who told me he was somewhere around post 70. He used to told me there is one thing. There is a postural muscle and a limb muscle dichotomy, in the sense they are doing two different things. He tells that he gets so much pushed to one side, he tries to hold on to something, but still he is going on being pushed for those few seconds. He tells, I don't know how I get that much energy during those few seconds. That is the thing. So the postural muscles are trying to push him to one side, whereas he realizes that he's falling. The limbs are telling that he's falling, so he tries to catch back. So that kind of a thing. One more thing is PPP. Yes, sir.
That's the reason they have mentioned a crisis, I think.
Yeah, yes, sir. Yes, sir.
Yes, sir. Yes, sir. You're telling about BPV.
One more is one patient post benign paroxysmal positional vertigo. Post repositioning, the patient is walking out of the doorway, and then he has an intense thud to one side, and then he bangs the head to the door frame. So that is one thing that has happened to one of my patients. So from that time, I tell, after a BPPV repositioning maneuver, you have to sit for 15 minutes in my OPD, then only go. So vestibular falls most of the time have that energy component. They are pushed. They are intense pushed. So that is what we have seen. Okay, sir. And with what you presented today, cardiac causes, then neurological, these things. Okay, we'll start thinking more in terms of them, and especially you made a very important point. Is like 3 days of Holter monitoring and util, but during those 3 days, that patient did not have the event. So what is the point of that Holter monitoring?
Any paroxysmal event, Dr. Srinivas, the golden rule is that you have to document it.
Absolutely.
Either spontaneous or by participating, and they missed it just because, unfortunately or fortunately, he didn't get that attack during the time.
Absolutely.
Please, again, emphasize that point. That's a very valid point.
Absolutely. So if the patient did not get it during that monitoring, then that monitoring has been useless. Yes, sir. That's a nice point. In fact, one of my ENT surgeon friends who is somewhere around 60 now, he also gets that he underwent same thing. He had a Holter. I was thinking in terms of PSVT, but going by the remaining history that he gave me. But he underwent a Holter and he told nothing came. Then I asked him whether during those days when you are undergoing the Holter, did you get it? He said, no, during that time I didn't get it. Then that monitoring was not going to be good. So a lot of new diagnostic things that we will start thinking of from now onwards, and we will stop relying completely on patients' history, telling that no, I didn't lose consciousness. You know that one of the patients whom you presented, they were not very clear about loss of consciousness, whereas the witnessed episode is there. And one more thing that you asked is about try to get a video. Nowadays, the thing is changing where a lot of places there is CCTV coverage. And the pattern of presentation of patients also has changed where they are coming with the CCTV footage of the falls.
Correct.
Now it becomes our responsibility to see diagnosed patterns and make out what exactly it is. For example, that patient whom you in the beginning showed, who was standing on the first floor parapet wall, and then he collapsed.
Yeah.
When that video was shown to me probably 2 years ago, I had multiple diagnostic possibilities in mind. But now with all the interactions and so much of reading and then interactions with you, now I will simply place it as a syncope. I will not bother about anything else. Yes, sir. Yes, sir. And one more thing that you showed, okay, a lot of things have happened. You also told people to look up at that Lempert's study on YouTube of 56 normal volunteers.
That's a very interesting study. You might have seen.
Yes, sir.
Tell me, sir.
So, which I think one of the main reasons for you is to share that is that to debunk the fact that myoclonic jerks do not happen in syncope. And there you have shown that myoclonic jerks. So really, it's an eye opener. I'm sure.
Myoclonic jerks is not exception. That is the rule.
That is the rule, exactly.
90% of the cases having myoclonic jerks in a syncope.
Yes, sir. Yes, sir.
The rule, but most of the time, it is very short and brief.
Absolutely, absolutely. One more wonderful point that you told that I've noted down is that temporal lobe seizures are not associated with loss of postural tone. Okay, these fine nuances help us a lot, because just a few weeks ago, I realized that there was a diabetologist's paper, combined paper, trying to document how the diabetic associated LOCs or whatever those things happen. Then what they found is in diabetic, hypoglycemia, loss of postural tone is not a common thing. Okay, most of them, like, they just black out even with maintained postural tone. So that was a very big news for me when I just read that paper of multiple diabetes. Now today you are sharing that temporal lobe epilepsy, again, postural tone is not going to be lost. If it is lost, then you'll have to think in terms of something happening to the heart, maybe because of the brain, but then it is happening to the heart. Such nuances we are accumulating. I'm sure as a community, we are all enriched. We are all enriched, and will continue to be helpful to help the cause of our patients. And sir, thank you so much for making your time out and sharing this wonderful presentations and insight. This is on YouTube, and I am sure a lot of people will continue to watch this on YouTube and will be overwhelmed by what they are going to be learning, and will be benefiting themselves and their patients.
Thank you. I think this was one of the best I have seen.
Yes. I wanted that to come from you, Surajit. I did not tell that, because I knew among the so many presentations that is going on, that there is something there is a slow improvement and slow pinnacle reaching. Okay, of so many things that we have come across. This, I think, is on the top. Okay, but then we should not turn back. Okay, the peak, we should keep making sure that the peak goes higher and higher. I get two more messages. Rinku Rehman says thank you very much for the information talk, and Dr. Abhishek Jaiswal, my friend from Himachal Pradesh, has said thank you very much. Dr. Abhishek, if you want to say something, you can unmute yourself and please do so. Please do. Vinod Kumar also says that.
Hello.
We'll share the YouTube link. Yeah, it's there available on the Cyclops Learning Lab. So if you go to Cyclops Learning Lab, the link is available.
Yeah. Hello.
Hello, sir.
Hello.
Yes.
Yes, sir. We are able to hear you, sir.
Yes, sir. Good evening, and I'm Dr. Abhishek Jaiswal.
Yes,
wonderful presentation. I was looking at the first patient, the videos that you showed us. I was just wondering whether, because you have mentioned in the charts that urinary incontinence can be a part of both syncope and seizure episodes.
Yes.
Is there
we can differentiate by urinary continence with the syncope or seizure, and both can. That is not a differentiating feature, and because tone is last, the chance of urinary incontinence is more common in syncope, but it is not all or none. That is not a differentiating feature. So the sudden regaining the consciousness, it's one clue to say it is a syncope, and the post-event confusion is a clue to say it is a seizure.
So as long as the patient, we can't get an episode either on EEG or on the ECG. There is no other way of means the patient. We just have to treat them symptomatically, isn't?
It's whatever you have to corroborate with other finding. Another thing that what I have not focused is the tongue bite. So tongue bite they have, it's more likely of epilepsy. So in syncope,
Okay.
it's lose the tone, so they don't bite the tongue very severely. So because jaw tone is also lost.
Yeah,
so
yeah.
bite it, so they can't
Yes.
bite. There may be injury in the tip of the tongue, but not the bite on the lateral angle. That's another clue to say it's generalized tonic-clonic epilepsy. If
Yeah,
tongue bite is not there. Tongue bite is
Yeah.
not there. Again, it can be both. So that's the way that
Okay,
we can-
can be both. Means a tongue bite. If their tongue bite is there, it is more. It is
more
seizure
likely,
only.
especially the
More
lateral
likely.
one.
See. Yeah.
So
This is a
syncope
wonderful
tongue bite
point
is
because
mostly teeth injury. It has to be fall produces injury.
okay, miss clenching of teeth. Even clenching of teeth. If the patient attendant says that the patient had clenched teeth or something like that, it is not very suggestive. But biting the teeth is basically injuring themselves, and they don't have any control over the whole issue, and that indicates goes more towards seizure, isn't it?
Yes,
Now,
sir.
that is a very good point. I just had a patient. I just was talking to one of my friend and having a similar kind of patient, and we were very stuck on that whether she is having a seizure episode or has a cardiovascular event as such, but nothing exactly same thing. The halter 3 times they have underwent halter for 48 hours. Nothing came on halter as such, but similar episodes. But she has urinary incontinence, and that's why the neurologist, my friend, was saying normally urinary incontinence will be pointing more towards seizure episodes rather than cardiovascular episodes. But that was the thing that I just that was highlighted on your slides. So I was just wanting to ask you. Thank you very much, sir. Thank you very much. Good night. Good night.
Thank you, sir. Thank you for the question. Thank you, sir.
Thanks. Okay. Good night, sir.
Good night, sir. So,
Yes, sir.
if there is any more questions, please do feel free to unmute yourself and ask.
If you, after seeing the YouTube, you can have that, you can again send a message to me. I'm ready to answer all your questions.
Yeah.
And the carry home message, don't think about the rare diseases. Common is postural drop. Never forget to record the BP in sitting, supine, standing, 3 minutes. Just 3 minutes is enough to say that there's a partial hypertension. Very easy, cost effective. That's the most common in the elderly. So
Yes, sir.
we should not miss that, especially when they are on multiple drugs and a lot of comorbid conditions.
Yes, sir. Sir, one more thing that happens is when patients check the blood pressure, when the clinician checks the blood pressure in the sitting position, and it is around 140 by 90 or 160 by 110 or 10, then what they think is it is not likely to be postural hypotension, and but then some of these I mean, not exactly in sitting position, in the supine supine position, or sometimes in the sitting position, but then all of these patients will have a supine hypertension. So in the supine position we see patients 200 by 120, and then when they are sitting there is a drop, and that drop is apparently within the normal range, but actually it's a postural drop. So I have had one such patient. Yes, sir.
Yes, sir. But what will be the complaint will be of more in the nocturnal headache.
Yes, sir. Yes, sir.
They won't present as predominantly as a drop in the standing related orthostatic intolerance or orthostatic hypertension.
Yes, sir.
With more of a nocturnal headache is one of the reasons that supine or isolated or exclusive supine or relative supine hypertension. We have to help these patients with giving night doses of antihypertensives.
Yes, sir.
That's a good point. But the entry point is a little bit different there. You're
Yes,
right.
sir. Yes.
Recording the BP always, even if you are not able to record at least by computer wise, that by machine wise you can record in standing posture when these people complain of dizziness.
Yes, sir. Okay. And one more point that I always try to highlight to people is this act of checking the blood pressure should be done by the physician himself or whatever. The only reason I tell is no offense to anybody, no offense to any nurse or whatever. But the fact is, so far, I have seen all doctors, when they take blood pressure, they take 1 minute, 1.5, 2 minutes. Sometimes they have difficulty in finding the Korsakoff signs. But till now, I've never seen a nurse who takes more than 30 seconds to record the blood pressure. Okay. They are so efficient, or it is just dropping, I don't know, for whatever reason. So the act of taking blood pressure, absolutely no offense, but this is an observation. So what for this patient where we are actually suspecting this kind of a thing, it is always better that the treating physician or somebody who he knows is very meticulous in taking the blood pressure does it. Sir?
Yes, sir. Yes, sir. I agree with you, sir. This is the most
Yes.
most important investigation or the important instrument in evaluating dizziness or giddiness is the BP apparatus.
Sure, sir. Yes, sir. Exactly. Okay, sir. Sir, and thank you again. Thank you so much. Okay, maybe this kind of grand rounds will continue and increase the grandeur of the discussions in balance related disorders, vertigo and balance related disorders. Definitely, you have increased the scope or the expanse of this subject by your presentation. And as Surajit pointed out, so far this has been the best. Okay, in among all the presentations, okay, because this is actually expanded something and brought in something very, very new into the discussion. I'm sure a lot of people have benefited. So with that, if no more questions are there, I'll take, there are something in the chat box. I'll just see that once. Okay, YouTube. Okay, that is nothing. Only thanks. So thank you. I thank you again, sir, and I thank you again for making this making yourself free and presenting this case. All of us are enriched, and I thank all of you for joining. And have a great Friday evening. Thank you all.
Thank you all.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir. With all your permission, I think I will end this.